broadcasting from Miami, Florida. Tonight we have a great show with a couple of people that deal with the heart. We have Steve Ryan, PhD, who's written an excellent book, Afib, afib.com, or I'm not sure, Afib. And Dave Albert, a noted inventor, businessman, and cardiologist from Oklahoma City in Oklahoma. We're going to be discussing Steve's book, and especially as it relates to reaching out to patients and how he's built a pretty solid network of atrial fibrillation patients all over the world. And then we're going to talk to Dave about his AliveCor, which is a device application for cardiac arrhythmias, and formerly it was marketed to, or doctors needed a prescription to get it, but now doctors can prescribe it to patients, and he's going to explain a little bit about that. So good evening, gentlemen. Could you introduce yourself just a little bit before we turn it over to Steve? Steve?
Sure. My name is Dr. Steve Ryan. I have a PhD from Ohio State in Educational Communications, but I do not have a medical degree, and I wrote the book Beat Your Afib, The Essential Guide to Finding Your Cure. And the great thing about this book is that it gives the facts of AFib, but more importantly, it gives people hope. It gives them a sense that AFib can be cured, that they don't have to live the rest of their lives taking meds, anticoagulants, that they can be cured. I've been cured for 16 years by a relatively simple procedure called catheter ablation. They run a catheter through a vein in your groin up into your heart, burn off or isolate the extra pulses in your heart that are producing the AFib pulses, and you're good to go the next day.
Okay, Dave, will you introduce yourself before we turn over to Steve?
Sure. I'm Dr. David Albert, and I'm the founder and chief medical officer of AliveCor. And I left academic cardiology to become an entrepreneur. I've been an inventor. My first patent I received while I was at Duke Medical School in 1983, so over 30 years ago now. And one of my latest inventions is the AliveCor ECG, which turns any iPhone or Android into a single lead instant rhythm assessment device. And actually we have many, many thousands of AFib patients who have bought our device. As Dr. Bennett said, for the first year, we began selling it really a year ago, January. For the first year, you had to have a prescription as a patient, or a physician could buy it. But just here 3 months ago, we obtained over-the-counter clearance from the FDA. So now AFib patients, and many, many have, can buy our device directly without a prescription and use it to essentially capture the rhythm anywhere. And we have a number of papers that have been published using our device, including at the 2 weeks ago, the Heart Rhythm Society, Dr. Khaldoon Taraji from the Cleveland Clinic presented an abstract on using our device to monitor post-AFib ablation patients, the procedure that the doctor was talking about, where they ablate the tissue that causes atrial fibrillation. And fortunately or unfortunately, oftentimes a single ablation doesn't work, actually in about 50% of the cases, depending on your center, and therefore picking up a recurrence of AFib is important so that those patients can be brought back in and potentially reablated, and the success rate goes way up above 80–85% after a second ablation. So he used our device, and we have ongoing research at Cleveland Clinic and a number of other institutions around the world.
Okay, Dave, we'll get into that after you both do your presentations. And well, a slight disclaimer here: please, for any patient, do not change your medication, your treatment. Please consult with your doctor before you do anything. And anything you hear on tonight's program, please consult with your doctor. Do not change your course of therapy. Okay, Steve, welcome. It's all yours.
All right, I'd like to commend you, Dave, for your device that's invaluable for AFib patients. To be able to just use your phone and capture your arrhythmia is simply wonderful for AFib patients. I can't tell you how many patients I know who go around checking their pulse all the time because they're never sure whether they're in AFib or not. And your device will make life much easier and simpler for many people with AFib.
Could you tell us about your book, Steve, basically what it's about and how it's structured?
Yes, my book is Beat Your AFib, The Essential Guide to Finding Your Cure, and it's different from almost anything else in the media today in that it says AFib can be cured and you should strive for a cure, and it tells you the advantages of being cured versus living for years on antiarrhythmic meds or anticoagulants, which over the long run can cause a lot of harm. For instance, if you take anticoagulants, you tend to get microbleeds in your brain, and if you take them for a long time, all of a sudden you have dementia. So what's the point of being on anticoagulants if you don't have to be on them? The ideal for everyone is to be free of AFib and not to have to take all these medications. So what I basically do in my book is I start off with, is this book for you? Should you read this book? And the whole point of the book is to communicate to people in a way that they can understand, that it's in language that they can identify with, and then they can tell that it's written by someone who knows what they've been through, who has had AFib. I've had AFib. I was cured 16 years ago. And so I know what it's like, and I hope I have the ability to communicate with people so that they feel, when they read my book, hey, this is somebody who really knows what's going on. The first chapter is, a simple overview, how AFib, how the heart should work, and how AFib works. In AFib, as you all know, for people listening, the heart normally, the upper part of the heart should pump down. In AFib, instead of that pumping down action, and then the lower part of the heart should send blood to the rest of your body, instead of that pumping action, in AFib, the heart goes like this. It vibrates, it quivers, it shakes. If you could look inside your heart, it would look like a plate of Jell-O or a bag of worms. And for people who have AFib, the biggest danger is clots, because blood stagnates in the upper part of the heart. You tend to get clots and strokes. Anyone with AFib, untreated, has 5 to 7 times more risk of having a stroke than a normal person. So AFib is really something that you need to deal with. So we go through and we explain AFib, we explain the heart, we explain how AFib can affect you in terms of not just feeling bad, but you're not getting enough blood to the rest of your body, to your brain. So you go to work, and all of a sudden things that you could do easily, you can't do anymore because your brain isn't getting the nourishment it needs, or you feel dizzy, or you faint, or you have swelling in your legs, or you develop other heart problems because of this AFib. So AFib is something, even though an attack of AFib by itself is not immediately life-threatening, if you don't deal with AFib, it will be life-threatening. Then we ask, how do you get AFib? Unfortunately, we don't know for the most part. Certainly, if someone has hypertension, if someone has sleep apnea, if someone has obesity, yeah, these are real triggers. Or heavy drinking is also a heavy trigger for producing AFib. But half the people have AFib, and we have no idea why. That was my case. I was in perfectly good health, and I developed AFib without any other health problems. And that's what happens with about 50% of people. Then how do you treat it? I go through all the various treatments. I go through medications. I don't recommend medications because, unfortunately, we don't have a magic pill today that will cure AFib. The medications out there today either don't work, or they lose their effectiveness over time, or they have bad side effects that you can't tolerate. So we just don't have a good medical pill solution for AFib. And we talk about all the different tests that doctors do, and of course one of the best ones now is Dave's monitor that you can monitor yourself. That's a wonderful device. Then we talk about mineral deficiencies and nutrition. That's something that doctors frequently don't deal with, and yet almost everyone who has AFib is magnesium deficient. Now you ask why? Because over the years our land has been over-farmed and there isn't enough magnesium in our normal food. So you have to make a real effort to keep up your magnesium source either with food or with supplementation. And potassium is another element that's usually lacking in most people with AFib. And we talk about different treatments. Cardioversion, electrocardioversion. That's used a lot, and it's effective, and it doesn't do you any harm, but unfortunately most of the time it doesn't last. But it's something that's worth trying at least once. Then we talk about pulmonary vein ablation, and that, of course, is, as far as I'm concerned, the main way that most people should expect to be cured, because basically once they burn off those pulses in your heart that are producing AFib, you're basically good to go. You're AFib free. Yes, there are recurrences, especially if you don't take care of the underlying problems like hypertension or obesity or things like that. Yeah, it can recur, but in general, people go take an ablation and they're cured. I was cured, and I've been cured for 16 years. We all talk about AV node ablation with a pacemaker, and I say, even though some people recommend that, I say that is the last thing you want to do. That is something of last resort. If you tried everything else, okay, but to wipe out your own heart's pacemaker and put in an artificial pacemaker is crazy if you don't need to do it. Don't do it. We talk about surgeries. There are things called maze surgery and mini maze surgeries, and we describe them all. They are sort of like a second tier below catheter ablation. Catheter ablation is non-invasive, it's not surgery, there's no cutting. Whereas if you start getting into surgeries, there's cutting, and there's a lot more risk, and there's a lot more trauma. And it's a toss-up whether it's effective or not. We discuss that very extensively in the book, and you can look at it yourself and make your own decision. Then we talk about pacemakers, and unfortunately pacemakers don't really cure AFib, and they, like an ICD, for instance, you put an ICD in, the problem with that is it shocks you, it feels like someone's kicking you in the chest. And with AFib, you can get kicked in the chest very often because AFib can come back a lot. So we don't recommend that. Then we describe a plan how you can be cured, and we give you a floor plan. We give you how to find the right doctor, how to ask the right questions to find the right doctor. We give you a plan so that you know that at the end of that plan you can be cured. Then we have a lot of stories. What we try to do is we try to describe every conceivable type of atrial fibrillation, from someone who's had AFib for 8 weeks or someone who's had AFib for 30 years and been cured. So we try to get every conceivable scenario where someone can be cured, and not everyone is cured. We should admit that. Not everyone is cured. Some people decide, I'm going to live with AFib and I'm just going to take my meds and that's going to be enough for me. And that's an option that you can choose if you want. So and then at the end I talk about counseling, and what I do is I try to be there for people if they want advice, if they want help, if they want to talk to someone who can understand them. One of the biggest problems of having atrial fibrillation is the fear, the anxiety, the depression, the lack of understanding the patient's experience. You don't have a broken leg, you're not bleeding, so people look at you and say, well, he looks okay, what's the matter? People, even your friends, your family, even your doctor sometimes don't understand what it's like to have AFib. And what I offer is someone who understands, someone who's been there, someone who can go over all your options with you, someone who can tell you who the best doctors are to go to, because that's very important. And I offer this counseling at a reasonable rate, but money is not a question. If you don't have the money, call me anyway. Doesn't matter. The important thing is you be cured of your AFib and get the help that you need.
Could you briefly remark, Steve, on the patient volunteers that you set up, the network of patient volunteers?
Oh, yeah. We have an AFib support network of people who have been cured and who offer themselves to give advice, to be there to help support people, to be like patient advocates. What I do, for instance, is if someone goes to a doctor in Santa Monica, I'll offer to go with them. And I'll be in the office when they have their consultation with the doctor. I'll ask questions, but most importantly, I'll just make sure that they cover the bases that they need. And then afterwards, I'll sit down with them and go over with them everything that they heard from the doctor, what they understood, what they didn't understand. My AFib support volunteers, I don't say that every one of them will do that as well, but many do. And the important thing is they're all across the country and all across the world, so that if you live in Texas, for instance, there's someone in Texas you can call and who will be there for you and will help you through this. They've all been through atrial fibrillation and they want to help other people.
I noticed too that in your book you always say to consult your doctor before you change your medicine, etc. Correct?
Yes, absolutely.
And you also have a directory of doctors in your book, correct? Of doctors that you think that the ones that you think are pretty good.
Well, the directory is not in this book. This book is more for beginners.
Okay.
The directory is in the website a-fib.com.
That's one of your patients calling.
Yeah,
all
right.
right. Okay, Dave. Any comments on what Steve had to say?
You know what? He said all the right things. Clearly, I'm not going to tell you which doctor to go to.
Okay.
I have too many friends who are electrophysiologists. It's an area I've been in for a long time, and there are a lot of very good ablating electrophysiologists. What you have to find is a cardiac electrophysiologist. They are the subspecialty of cardiology who perform pulmonary vein isolation and the other types of ablation procedures that are being done today. And I can tell you there is ongoing research and innovation to improve the success of ablation. There are catheters that freeze it, there are catheters that burn it, there are new mapping technologies, incredibly sophisticated devices and systems that are all aiming to improve the ultimate success rate of ablation.
Excuse me, Dave, could you move your camera up a little bit? We're just seeing the bottom. Yeah, we're just seeing the bottom part of your head.
Yeah,
sorry,
there we go.
Sorry.
No, that's all right. In fact, I'll get a little. There you go. So basically, I'll just talk a little bit about atrial fibrillation. Okay. Atrial fibrillation is a disease. Steve was relatively young because he's still a young man. Okay, he was relatively young when he had his first AFib, but AFib is generally a disease of aging. So the vast majority of AFib patients are over 65, and the incidence of AFib goes up with each decade. So there is AFib under 40, but very, very little. 40 to 50 a little bit, 50 to 60 more, 60 to 70 we start to see, in percent you can calculate, and then over 80 it's 10%. And it rises exponentially with age. So it is a disease of what we now understand, atrial fibrosis. That means in some people, as Steve said, we have no idea why they have it. But we do know, and I have a good friend of mine, Dr. John Mandrola, who blogs for the American Heart Association, theheart.org. He's an electrophysiologist who does AFib ablation and who has had AFib himself and been very public about it. So I'm not breaking a HIPAA rule here. He has blogged about his own AFib, and I was just with him at Heart Rhythm Society, and Dr. Mandrola talks about the two phenotypes of AFib. One is probably like Steve, in shape, white male, successful, a lot of professionals, like John. He was a competitive cyclist, cardiac electrophysiologist who developed AFib. That's one phenotype. That's not the biggest, but it's enough that we see people like John, and I've seen lots of men in their 40s, late 40s, who develop atrial fibrillation, what we call paroxysmal. It comes on suddenly. Sometimes it goes away by itself, but oftentimes it doesn't. And those, by the way, like Steve, are the best candidates for pulmonary vein isolation. They are the ones most likely to be cured with a single procedure because the damage to their heart is limited. Now, an 80-year-old person who's had AFib for 30 years, I can almost tell you they've got hypertension, they probably have some coronary disease, some atherosclerosis, they may have diabetes, either type 1 or type 2 more likely. Those are all risk factors associated with the incidence of atrial fibrillation. And those people, there are different types. I talked about paroxysmal, comes on rapidly, goes. Then there's persistent, and there's long-term, and we change the nomenclature. I can tell you, they keep changing it. And how successful ablation will be, and I'm a huge advocate for ablation. If you're the right patient, it is a cure, okay? And very seldom in medicine do we cure anything. For instance, a stent is not a cure. You prop an artery open, but you haven't stopped atherosclerosis. So an ablation can be, like it was for Steve, a cure for your atrial fibrillation. And that's magnificent, okay? No anticoagulation. And by the way, that's controversial. In this country, we now have monitors because some people will have recurrence. It may come 1 year, 2 years, 5 years. Another good friend of mine, Dr. Jonathan Steinberg, who's professor at Columbia, just published in Heart Rhythm Journal 10 years, long-term follow-up on ablation, successful ablations, and he meant successful by more than a year of no recurrence, and he had 70% at 10 years be cured. Steve is obviously an example of that type of patient. But what you'll find is those people that have had it for 30 years, 20 years, who are 75, 80, they're much harder to cure because another famous ablator, Dr. Nasir Marouche from the University of Utah, has shown using MRI that the top chamber of the heart becomes filled with fibrous tissue, not just muscle. And that fibrous tissue creates a maze. And as a matter of fact, I trained at Duke. And so Dr. Jimmy Cox, who created the maze at Washington University, and Ralph Damiano, who's his protege, they both were friends of mine from 30 plus years ago, they try to stop a maze with a maze. So you have a maze of fibrous tissue and muscle. It creates this disorganized stimulation, and they try to do it. Obviously, it's much easier if you can have a catheter and not have to have open chest surgery. And so, obviously, ablation using a catheter is much more popular than the surgical ablations are. What I will tell you is our device, and I have one right here on the back of my iPhone 5S, is literally used by now many thousands of AFib patients. And what it's used for is a couple of things. First of all, we just published a study about 2.5 months ago where in 10 pharmacies in suburban Sydney, Australia, Professor Ben Friedman of the University of Sydney screened 1,000 people over 65. Now, these people were coming in to get their medicines at a pharmacy, and they were over 65. And we diagnosed 1.5%, or 15 people out of 1,000, with undiagnosed AFib. Now, it turns out that that was a pretty dramatic percentage for people just coming in. Aha, why did we have such a target-rich environment? Because those people, the average age of those we found was 79 years old. And they were coming into a pharmacy to get medicine. What do you think they were getting? Blood pressure medicine, statins, diabetes medicine, all the risk factors for AFib. So that was a target-rich environment. But it proved that we could take a 30-second recording and pick up AFib using an automatic algorithm, by the way, which is in my safe harbor is in the FDA right now, has not been cleared yet, but if we are fortunate, you will have automatic high predictive value AFib detection built into an iPhone or an Android. So you'll be able to have instant feedback for anyone as to whether or not what they're feeling is AFib or not. And we're very excited about that.
Excuse me, Dave. You know, one of the values I found in Steve's book was he kind of plugs you in with those educators, and that's something you're talking about with the AliveCor. Is one example of how patients can educate other patients.
So
they can tell them exactly what you're saying.
Well, that's the power of our social networks, right? We have this viral communication today via the internet, via the Facebooks, the Twitters, the LinkedIns, so that people, and they're the patients like me and other patient-specific networks that allow people to educate people. I mean, Steve's a professional educator. He's a PhD. He understands that and is able to communicate that in his book. We're a small company, but we've been relatively successful in a year and a half of getting our product through the regulatory business. I mean, I was chief scientist of General Electric Cardiology. I have 50 patents. I've done this a long time. I'm not quite a young guy anymore. And what I will tell you is, I myself carry this and use it. People like Dr. Eric Topol, he's diagnosed heart attacks and AFib on airplanes using our device to a lot of press coverage. So we know it's useful for diagnosing. What I just told you earlier, the Cleveland Clinic just published an abstract. So once you have an ablation, there are different protocols for following up because, unfortunately, a certain number of ablations don't stick the first time. So a non-insignificant number of people may need a second ablation. I know people have had 3. So what you want to do is pick it up as soon as possible because you don't want people continuing to, we tell them come back in 3 months, come back in 6 months. Well, what happens if it recurs in 2 months or 5 months? So the Cleveland Clinic, maybe the best cardiology program, so says U.S. News and World Report in the world, provided our devices to patients. And every day they were able to record their ECG in any time they had any symptoms at all. Because, as Steve knows, today we ablate symptomatic AFib. But anywhere from 40 to 70% of AFib may not be symptomatic. Now, I contend that those people actually are symptomatic. They've just gotten used to it. When you're 75 years old, a lot of people say, I'm old, I should feel tired. Not true. Right. And that's why, in Europe, they have this thing called Know Your Pulse. Well, I can tell you, we've tested that. It's hard to get a 75-year-old person to be able to detect what we in medicine call the irregularity of AFib. It's really easy for them to hold a device like ours in their hands and 30 seconds later get a highly accurate answer. And I think that's, so we see AFib as this community of 3 million that many people predict because of obesity, because of the aging of the population, may go to 16 million in the next 10 to 15 years here in the U.S. Truly an epidemic. And so we've got to get better at diagnosing these people early and then getting them into ablation, curing it. Because you can't turn on the TV today on prime time without seeing an ad for Xarelto, for Eliquis, for Pradaxa. Those are the new anticoagulants. Well, I will tell you one thing. They are not without risk, but what's important to a lot of people is your copay is probably $100 to $200 a month. That's one medicine, $100 to $200 a month. There are a lot of people living on Medicare and Social Security for whom that is just not possible. Right. And warfarin, which has been our tried and true medicine, is really problematic to manage. I mean, you can't eat certain foods, you can't take certain medicines, you have to have this blood test called an INR test. It is problematic. We'd love to replace it, but the problem is it's very inexpensive. And I can tell you throughout much of the world where they have socialized medicine, they're not going to have a choice to use the new drugs. You're going to have to use warfarin. And so, hopefully we're able to train a lot of people to become ablaters. And I think that, that clearly represents the best opportunity, the only opportunity, as Steve said, to cure this problem.
Well, when I read Steve's book, even though I went to medical school, I didn't know ablation was in some cases so successful. I didn't know that. I thought you just had to live with AFib and take warfarin the rest of your life. So I bet you a lot of patients are kind of in that situation where unless they're proactive and aggressive, asking, my brother has it. He's in Hawaii, and I told him, talk to your doctor about ablation. Consider it a possibility. And I wasn't even aware of that until I read Steve's book. So
well, I think
patients
Steve will tell
need to
you.
be educated.
Steve has that network of advocates, and I think that's very important. Steve, I'd love you to hear your comment, because if you leave it to your doctor, they, A, may not be aware of it themselves, or B, oftentimes there's this notion, AFib used to be considered the low back pain of cardiology. That's what it was, okay? We basically controlled their rate and put them on warfarin, all right? That's how it was treated for 25, 30 years. You gave them at first digitalis, then beta blockers, calcium channel antagonists, and you put them on warfarin. And you told them they couldn't eat leafy vegetables. They couldn't eat the things that are good for them, by the way. They couldn't take certain medicines, and they had to watch out because they could bleed if they fell. They had serious risk. And so I think I'm an advocate for Steve and his network of people, because patients must become empowered to stand up for themselves.
Yeah, I could see that firsthand as a patient, not as a doctor, because I had some questions. I want to talk about medications, and I literally had to chase my cardiologist down the hall to ask about, when will I be cardioverted? When's this going to happen? When's that going to happen? And so Steve's book plugged me into another patient in the area. We discussed ablation, we discussed other things, and we also discussed getting a monitor. You probably know which one it is, Dave. But what kind of monitor you wear on the wrist to tell me my heart rate. So when I ran, I didn't go dangerously high. Little things like that, which doctors don't have time to discuss about, the importance of monitoring your rate when you exercise, things like that, which I found that patient network invaluable for me as a patient.
Well, patients want to talk to patients. To be honest with you, we all want to talk to people who are going through what we go through. And as a doctor, oftentimes, first of all, we get to spend about 4 minutes with a patient now. I mean, that's an exaggeration. You get more like 6. Okay, yeah. So, and you spend the first 2 minutes, how you doing, how the kids, kind of thing. So, doctors are under tremendous pressure today. The second thing is that they're comfortable with what they know. And ablation, while Steve had one 16 years ago, that was very early for AFib ablation. And Steve, I'd love to hear, I don't know where you had yours and who did it.
In France.
Bordeaux.
So you went to Bordeaux. Okay. Well, there were people here like Andrew and Natalie who were doing it. At the University of Oklahoma, we had this guy, a famous cardiologist named Sonny Jackman, who was doing ablations 25 years ago for Wolff Parkinson White syndrome and AV nodal reentry tachycardia and other things, but wasn't a pioneer as they took that technology of catheter ablation and applied it to this insight that these abnormal pulses came from the pulmonary veins bringing blood back from the lungs, and that really started this notion of isolating the pulmonary veins with these circles and stopping AFib. And it's a wonderful procedure when it works, and as I said, unfortunately sometimes now you got to have a couple of them, and they're getting better, they're getting faster, and we're learning more. So I think it'll only keep getting better. The problem today is most ablaters are booked up. There are way more AFib patients than there are slots for ablations.
Is that because patients are becoming more educated and finding out it's out there?
Yes, and here's the other thing. Now, this is not a cheap procedure. Okay, so you've got to go. I can already tell you there are insurance companies that are balking because a couple of ablations, that's way over 6 figures, my friend. I mean, it's a significant amount of money, and you've got to understand, you know, how does insurance work? You pay in a lot of money and you pay out a little. That's called the profit motive. And so, you know, it is what it is. And I think, you know, the costs will come down because it'll get faster and easier and things, but it's still going to be a procedure that requires real expertise, real technology, but has great outcomes. So, you know, it's just getting better.
Steve, how were you? Were you pretty proactive when you got the ablation? Did you have to literally demand your cardiologist, or you just looked everywhere to find someone that would do it, even consider it? You had to go to France, didn't you?
Yes. My case was a little special, John, because back in '97, nobody was doing it here in the U.S. I had to lock myself in a medical library for 6 months, read up all about how it's treated and I found that Pacemakers in France discovered a method of curing it through catheter ablation, and I mean, to me, going to France was like going to Mars, but you know, it eventually came to my mind that if I'm going to be cured, I've got to go there, and so I went, and I was their first U.S. patient. But of course, today there's thousands of good EPs in the U.S. and around the world who are doing catheter ablations. One thing I want to mention, John, before we get any further, is that the average person with AFib is getting a lot of misinformation on the internet and in the media.
Okay.
And what I mean by that, well, let's give you an example. womensheart.org, a very professional website, put out a quiz, and they said, well, one of the questions was, can AFib be cured? And I answered the quiz, and I said, I've been cured for 16 years. Yeah, it's curable. So, but their answer was, there's no cure for AFib. AFib can't be cured. And I'm saying, what?
Okay.
You know, I'm saying, how can they say this? And of course, I write them and I give them all the references that you can imagine of how AFib is cured. They never write back. So that's the kind of thing that you're going to run into in the media. And then, of course, why? Well, you look at all the people, all the sponsors of womensheart.org are pharmaceutical companies. They're not interested in getting people cured. They want
atrial fibrillation not caused by a heart valve abnormality. You can't turn on primetime TV without hearing that blurb from one of the new, you know, J&J or Bristol Myers Squibb, Boehringer Ingelheim. They want to sell their drugs.
Living with AFib is the emphasis of today's.
That's right.
Not being cured. Live with it.
That's correct. He's absolutely right.
You know, Dave, you mentioned John Mandrolo's name, certainly a well-known cardiology blogger. In my conversation, one of my conversations with him, we were discussing atrial fib, and he says in Australia that they're working some kind of dietary thing.
Yeah, well, I can tell you about it.
Can you comment on that?
Sure. Dr. Prash Sanders at Adelaide has, in JAMA in October, published a phenomenal paper. And basically, I mentioned to you the young, fit, white, stressed-out AFib phenotype. That's the less prevalent type. Well, the major type is older, obese, hypertensive phenotype. And Dr. Sanders, who is basically took a group of those, what I would call the common AFibs. Okay, they're older, over 65, they're overweight, hypertensive, and randomized 2 groups. In both groups, they aggressively managed their risk factors, their lipids, their blood pressure, but in one group, they aggressively managed their weight. And they had dietitians, they got them their own meals. They provided the meals for these people. And after a number of months, they evaluated both their symptoms and their AFib burden. They did a 7-day recording of how many minutes of AFib. And the group that was on the aggressive diet, well, first of all, they lost a lot of weight, and they had significantly lower AFib burden and symptom burden. It was major league. And they just presented another paper at Heart Rhythm Society showing that this was sustained, and that in essence AFib, and the stress, it's part of the reason why the incidence of AFib goes up. You don't have, you're going to get older, but look around you. I don't care if you're in Florida or I'm in Dallas today or wherever you are, you're going to see a lot of obese people in the United States. We have an epidemic of obesity. And with obesity comes an epidemic of hypertension, comes an epidemic of type 2 diabetes. Those are all independent risk factors for AFib. And so whatever your normal risk profile in your DNA was, you can make it a lot worse, and we're doing that. So, Dr. Sanders has now shown that you can decrease. And so Dr. Mandrola is a huge advocate, and as he tells me, in his AFib clinic, it's a lifestyle modification clinic. So, for those patients, whether he ablates them or not, okay, he's saying, guys, we got to change how you live. And by the way, our whole society has to. I give a lot of talks all over the country, and I was on the faculty at HRS and at ACC, and I'll tell you what, I'm from Oklahoma, and I own a ranch, but I tell people now, eat like a cow, don't eat a lot of cow, okay? And that's what we need to do. We need to eat better. We need to eat more fruits and vegetables. We need to stay active, stay fit. You need to watch your weight, because those things clearly contribute to the burden of atrial fibrillation. Atrial fibrillation does have a genetic component, does have what I would call a non-controllable component, but clearly has a large controllable component, as does coronary artery disease, as does type 2 diabetes. I mean, we have lifestyle. AFib has a genetic and a lifestyle component. And you can, the genetic one, that's what we want to cure with ablation. The lifestyle one is where we've got to get our patients engaged and empowered. And Steve is doing that with his network. He is getting people educated, engaged, and empowered. And I can only applaud you, sir. Thank you.
Could you please comment, Dave, on what Steve said about magnesium? Do you address that in patients, or?
To be honest with you, first of all, I don't practice now, so I can't. I'm not going to comment on. And I don't comment on specific things. Okay. I leave that to guys like my friend John Mandrola or Wes Fisher, who are AFib bloggers. My friend John Steinberg, Nasir Marouche. They each have. But I will tell you that nutrition is important. I want to give you one little example, and I think I said this on our last meetup. Okay. I graduated from Duke Medical School, pretty good medical school, in 1981. I didn't have 5 minutes of nutrition education.
Yeah, you mentioned it. Yeah.
I did not have 5 minutes of education about physical fitness and weight management. Not 5 minutes. My son is a second-year medical student at the University of Oklahoma. He had weeks of education on fitness, nutrition, aerobics. I mean, Dr. Ken Cooper, who coined the term aerobics, is a University of Oklahoma Med School graduate. So they've got a Ken Cooper Center. But Ken Cooper was a pioneer. In the 1960s, he wrote this book Aerobics as an Air Force physician. The rest of us were just stupid. We didn't. He got it long before the rest of us got it. But today, we all get it. And so John Mandrola says, my AFib clinic is a lifestyle clinic. I can help some people with ablation. Some people are going to. I need to help them with lifestyle. And I think we all need to take our lifestyle personal responsibility and getting people to support you. That's the patient network that John has. I mean, that Steve has. So please keep that going. I'm looking at John's name. That's why I said that.
That's okay. Well, you guys, this is great for education. I think for patients to hear this, hear you guys talking about this thing, and I certainly appreciated reading Steve's book and getting plugged in with patients in the area, and to have you, Dave, talk about the various methods of being treated. I think it just shows the power of the internet. And like you say, patients get educated, get empowered, and I think anyone will generally say that an educated patient is in much better shape than a patient that's not educated. He'll be more compliant with his medication. He'll take better care. He or she will take better care of themselves. So hopefully we'll use the internet
Absolutely.
to spread education. So, gentlemen, I thank you very much for coming out tonight, and I hope you come back. I'm going to sign off and just hang on. Good night.